Gregg Meyer is the Chief Clinical Officer at Partners HealthCare. He has a long and illustrious history in quality, safety, and population health. He is also a retired Air Force colonel, which is a great thing. My son's in the Air Force, so we bonded over that. Did a stint at the AHRQ, so he has some government in his past. He built the quality and safety program that we currently have at the Mass General from scratch, was recruited away to Dartmouth-Hitchcock to be their chief medical officer, and then my Uber boss, Gary Gottlieb, recruited him back to be the chief clinical officer at Partners, where he oversees population health, the eCare initiative, which is what we call our EPIC implementation, quality and safety, and connected health. And it's been a pleasure and a blessing to have Gregg as our steward to add connected health in a very real way to the fabric of care at Partners going forward. And would love to talk to any of you about that at a break or a cocktail reception, how just changing leadership makes a big difference. But without further ado, my boss, Gregg Meyer.
Thank you, Joe. Let me begin, first of all, by thanking all of you on behalf of Partners HealthCare for being here at Connected Health. And as I was reflecting on the talk this morning with Joe, it reminded me of when I first came to the Connected Health Symposium a decade ago. And at that point in time, I remember walking through, I was the medical director at Mass General at the time, and I walked through the exhibit hall and sat in some sessions, and the whole time I was thinking, two big questions. Like, boy, there was this really cool stuff and really great ideas. And I said, but what do I do with it? And why would I want to do something with it? What I want to do in the next little while is share at least one health system view on both the why and a little bit on the what and the how. And the why, is, I think, well illustrated here. That one of the things that Mass General does well, dating all the way back to our first chairman of the board, who was John Adams. And John Adams and the trustees said, from the opening of the hospital we keep track of deaths within the hospital and also the cost of that hospital stay. And what you see here is you see in the fuchsia squares there, that upper curve there, that is the hospital mortality of Mass General over 200 years. And I will be the first to argue with you that I don't think mortality is such a great quality measure. But over 200 years, it's kind of interesting. You can see in the 19th century, most of those peaks are due to things that happened outside the hospital, cholera epidemics and other things that were happening in the Boston community, the Civil War. There is one peak that occurred in the 19th century that you can see early on, the biggest peak in the whole curve there, and that was beginning in October of 1846. Wow, that's awful precise, isn't it? Began in October 1846. And what that was actually after the introduction, the first time of a public demonstration of anesthesia, which occurred at the Mass General. What you can see there is that we started to do a whole lot of things, and our surgeons had a little bit of a learning curve over the early 19th century there, and that's that big peak there. What you see during the 20th century is that decline, but look at the little blue diamonds, because that's the cost in $2,010 of a stay at Mass General. And the why of all the things that you're doing being so important to my role in a healthcare system is because if you look at those blue dots and how steep that line gets at the end, and you look at the flattening mortality curve, you do not have to be a card-carrying economist to say, this is the law of diminishing returns. We have to do something different. This is not sustainable. Now, when I talk to my colleagues about that, one of the things that they remind me of is, boy, we tried to work on managing care in the 1990s, and for a lot of physicians in this country, that didn't feel so good. It didn't work out so well. Many of you will remember the movie here, Helen Hunt, Jack Nicholson, As Good as It Gets, and a scene in that movie, Helen Hunt complains about her son, who has asthma, not being able to access the care that he needs. Specifically, she wants her son to see an asthma specialist, a pulmonary doctor, and the goal is to get her son to be able to play soccer without having to go to the emergency room. And in the movie, she bangs the table because she's so frustrated. She says, damn that managed care. And that drew spontaneous applause in movie theaters across the entire country. Now, I remember that time very well because there was one other scene in the movie that drew spontaneous applause. And that was when that big spaceship thing hovered over the White House on Independence Day and it blew up the White House. Well, at that time, I was actually working in the White House, so it didn't feel so good. But this is tapped into something very deep. People said, boy, something's wrong with managed care. What's different now? And I would argue there are 4 things that are fundamentally different. Funding. People in the 1990s will say, we didn't fund it properly, we ratcheted down payments too soon. That's being solved, to some extent, by building accountable care off the chassis of fee-for-service payments. 2 other issues. The quality issue. Well, back then the reality was that Helen Hunt had a pretty good point in that movie. We didn't know how to measure the quality of care, and the way to make the most money, if that was your goal, would be to skimp on care that was necessary. We're much better now at measuring quality, and we're not as good as we'd like to be, but we've made a lot of progress. So we now, for example, in accountable care, to be able to get access to those shared savings, you have to show that you've met a certain quality standard. There were a lot of complaints about the ability to access providers and have choice. And accountable care says, you can go wherever you want. If you're a snowbird and you get your care at Mass General, you get your care at Dartmouth-Hitchcock during most of the year, but you spend 5 weeks in the middle of the winter in Naples, Florida, where there are 5 freestanding MRI machines on one city block, that we are held accountable for that, but you still have that free choice. But I would argue to you that probably one of the biggest changes between the 1990s and now, and why I can feel much better about it, is all of you. It's information technology, and it's telehealth. Well, we know, when you look at all the medical evidence, that there are about 20 things that you can do that actually have been shown to improve the quality of care for patients, improve their outcomes, improve their experience, and also to make care more efficient. 20 things we can do to it's not an infinite list. The medical evidence is pretty clear. This is work from my colleague Tim Ferriss, and you can categorize these pretty quickly. And what you end up with is you end up saying, okay, well, how do we put that into place? And one of the things that we've done is say, here are all the things that Partners HealthCare needs to do to make population health medicine work. But I think all you're asking the right question. If you have 20 priorities, you don't have priorities. How do you get started? And so this is the way that we're trying to get started. Looking at this in 3 phases. And that first phase is focusing in on those patients who are in that 5%. Those patients who are going to be the most neediest. Those patients who are where the puck is going in terms of healthcare need, trying to anticipate those needs and meet them differently. So when we look at the whole spectrum of care, going from patient and family self-care all the way through to quaternary care in an advanced academic health center, the traditional care models were pushing everybody over to the right. They were escalating that care. Under risk models, we're now trying to push care in the other direction. And as we do that, though, the first place where we look for savings is on that far end. And so the kind of 1.0 opportunity in population health management is say, what can we do in high-cost, high-needs patients? We now can say that we know how to do this. And this comes from some experience that we've had at Mass General with some of my colleagues putting together a care management program which focused on that small number of patients who are going to be the most needy over time, recognizing that these weren't patients that had high blood pressure or diabetes or cancer or substance abuse or depression or rheumatoid arthritis. My patients as a general internist, they are the F patients. They are all the above. And for those all the above patients, the challenge and the opportunity that we have is that woman down there in the lower corner. And what you can see is she's sitting at a table with a table full of medicines. Right? Her cardiologist has her on the best 5 medicines to control her heart failure. And oh, by the way, her psychiatrist is doing a terrific job with those 2 meds for her depression. She's feeling pretty. And her arthritis pain is doing okay with the 3 meds she takes for that. And by the way, her diabetes is doing terrific with the combination of the insulin and the pills that she takes. Now here's time for confession. How many of you here can take a 3 times a day antibiotic for a week perfectly? Right? Liar, liar, pants on fire. Somebody up here actually raised their hand. Right? So the notion that we expect patients to do that, That's delusional. And what we've shown is that we can put together a care plan using care managers in the office, using customized care based on modules to try to provide a solution for each of these patients, which when the Congressional Budget Office looked at it, for every dollar the government spent on this program, they got $2.56 of savings. And oh, by the way, we reduced mortality by 4%, an absolute mortality benefit of 4%. If this was a pill, the trial would have to be stopped because it was unethical to continue it. We know how to do this now. So this is 1.0. We've figured this part out. And it's important to remind ourselves that telehealth played an important role in that. So this shows some data from our connected cardiac care program and just shows you the impact of telemonitoring that helped us achieve some of those results. But what's the next opportunity? And I think the next opportunity is starting to think, other places where a lot of the costs are the exact opposite end of that spectrum, on that self-care side. And what can we do focusing on that 2.0 level opportunity in population health? And one of the first things that we need to do is to start to build out this spectrum. And many of you will see some of the things that you've worked on up here. And what we are trying to do as a health system is say, how can we get these pieces to fit together? How can we have some sense making of all the inputs that we're getting from these? How can we ensure that we are able to keep that patient at home for as long as possible? We're able to deliver services at home, yet at the same time, we're able to look longitudinally, anticipate what they're going to need if they ever do need to come into the hospital here. And so putting together all these pieces. How do we do that? Well, places where we're starting at Partners is we're starting on virtual visits. And here you can see that we're pushing hard to move out virtual visits, for example, our pediatric population. Some of you saw in one of the earlier sessions today, some of our neediest kids. And what you can see there is that we have this tremendous opportunity to bring services into the home because it's so difficult for those parents to, when they have so many other things to attend to with their child, to take the time off to get them into our facilities. We're also building out our curbside consults. We're trying to bring more rigor through technology, through what used to be a conversation that I would have in the hall with my cardiology colleagues. I'm a primary care doctor. Say, what do you think of this? Well, why don't we make that easier to do? Why don't we allow it to be not just serendipitously meeting somebody in the hall, but creating that space where we can constantly answer these in real time, give that information, and decide who actually needs to go on to see the cardiologist. We're also using monitoring and also using behavioral health to try to influence the way that our patients are managing their chronic conditions. So here you can see some work again from the Center for Connected Health looking at some of the things that we've been able to achieve with our diabetes program. This is a combination of using those glucometers, of downloading that data, of providing feedback to patients, and now taking that next step to using those social interactions through media to try to direct those patients to improving their health over time. EConsults, another simple thing that we've started to build out again with the help of all of you in putting together these technologies. We're just starting on this. When we come back and we show this data again, I think we'll be tenfold higher in 1 year's time with our use of EConsults. Virtual visits. How do you actually, it's wonderful to see all the technology out there. How do you actually get them into place? How do you get your physicians to use them? What we're doing right now is we are piloting it in a number of our areas and finding very quickly that, yep, there are those challenges, but we can work through those with the new technology much more quickly. And we're relying on both our synchronous virtual visits, but also saying, what can we do asynchronously? What can we use to level load our providers? Because from the provider perspective, all of the wonderful things, and there was a terrific slide earlier in the morning here that showed the one view of the world is, oh my goodness, the good thing is that we have all of this data. And from the provider's perspective, the crazy thing is, oh my goodness, we have all this data. So how do we start to think about how can we level load their lives and think about what are the answers that we need in terms of what works best done synchronously, what works best asynchronously. Our virtual visits now are being rolled out through 5 departments, and by the time we come back here in a year's time, we'll have spread these much further. We're seeing this increase at a very, very steep rate. Why? Because the physicians like it, because the patients like it, and oh, by the way, through the work of all of you, the technology is usable. 10 years ago, if I had to show this slide, it would look a much flatter adoption curve. So we're able to get to a relatively steep adoption curve. We're also using new tools for patient engagement. There was a session earlier today talking about behavioral health. How do we get patients involved in it? One of the things that we can leverage are the tools that we can get over our mobile phones now. For example, VidScript. It's so powerful for a patient to be able to go back and say, well, here's what Dr. Meyer really asked me to do. And oh, by the way, I can play it. I can show it to my family. The notion we've had in the past is, boy, if you want to ensure that you're going to get safe health care, you better have somebody come with you, right? That's an awful big burden to place on our patients. But freeing patients from having to come into the office at all, or if when they do, that they're able to capture the information, bring it back and show it to their family in a reusable form, it's a game changer for us. Trying to collect the data to see that all this is working. Another place where we're working right now is trying to say, what are the most efficient ways to collect patient-reported outcomes? We know that we can make a difference with this technology. We also know that most of the extant measures of quality aren't going to capture it so well. Wow, we can show that we can control somebody's diabetes and lower their hemoglobin A1C by 1.5%. That's terrific. It's important. It will make a difference for those patients. But the real value of the technology that you bring to us and that we're trying to consume is, how can we make that patient experience easier? How can we get better? What are the ways to capture those outcomes? And so working on patient-reported outcomes is another place where we're now trying to push our program forward. Now, with all that said, there's the opportunity that I'd really like you to think about and to work on for us. Because when I think about what we're trying to do in population health, I think we're leaving what is probably the biggest opportunity on the table. And many of you know this data, and it was drilled into your heads in public health school or in a health class at some point in your life. And what someone told you is still true, and that is that if you look at what makes us healthy, if you look at what helps create health in a human being, that healthcare delivery, what I do every day, that's responsible for about 10 or 15%. Our behaviors are about 40%. What goes on with our socioeconomic situation, the influence of our patient, all of those may contribute. So how do we start to move away from just healthcare delivery to looking at those other aspects of behavioral management? And that's one of the most exciting things that I've had a chance to see here today, is that in the past it was all about how can we deliver healthcare in a different way. We're starting to say, how can we actually look at health more broadly and think about how can we deliver behavioral change in a different way? How can we deliver some solutions to the circumstances around housing, around nutrition, around diet and exercise differently to our patients? And so I think the big opportunity for all of you in the future in population health is to think about trying to bridge two worlds. And those two worlds have traditionally been the medical care system on one side, where we provide direct service to patients, and the public health system, the community healthcare system out there. And this is some work that came from my colleagues in Dartmouth. And what they recognize is that, the medical care system is really good at some things. And when it comes to taking care of really sick and needy patients, that is what they do best. The public health system does some wonderful things as well, ensure that we have clean water and we have safe food to eat. But the truth of the matter is that there is a huge opportunity where these systems come together. I can't do a good job providing patient-centered primary care without understanding what's going on in the community. The community can't do a good job of protecting vulnerable populations without me as a primary care provider. How do we integrate those roles? How do we pull those pieces together? And how can telehealth help us with that integration? So what I saw this morning were some wonderful tools to help us deliver healthcare delivery better, more efficiently. I also saw some terrific tools looking at behavioral health and how can we start to influence the way that the patients behave and their social circumstances and their diet and exercise. And what I'm challenging all of you to do is help me with the next part of population health management, and that's going to be, how do we pull these pieces together and how do we create data that we can use? When I think about where we're going in healthcare, one of the things I always remind ourselves is I showed you that curve earlier, and I could have showed you a number of curves that look at healthcare costs in America and what's going on and how unsustainable it is. And one of the few things that can make me feel better, but it's only for a little while because I have one child recently out of college and another one right in the middle of it, is that the one place that has a bigger challenge even in healthcare with costs right now is education, right? And so this shows you the consumer price index and shows you that although healthcare is way above the consumer price index, in fact, the cost of education is even higher. Think about for that a minute. Another service industry, trending really high. What are the tools that have been brought to bear? What is going to be, when you think about trying to pull together massive communities focused on improvement, what is going to be for healthcare? What's going to be our edX equivalent? Thank you very much.
Thank you, Greg.
Thank you.